This conference will now be recorded.
Okay, good afternoon everyone. Am I audible? Today we'll discuss about tuberculosis of a female genital tract. Coming to the introduction, the first authentic description of genital tuberculosis is attributed to Morgagni and Robert Koch discovered the organism Mycobacterium in 1882. And coming to the incidence of this female genital tract TB, it is almost 10.3% in India. And among the pulmonary tuberculosis, which develop into genital tuberculosis, it is around 10%. And coming to the female pelvic infections, this general tuberculosis, it accounts for 5%. And those who are presenting with infertility, it is present in around 10% of females. And coming to the pathogenesis, as we all know, the common causative agent is Mycobacterium tuberculosis. It accounts for 95%. And apart from the Mycobacterium tuberculosis, bovis also causes genital tract TB. It accounts for 5%. And this genital tract TB, it is almost always secondary. Primary genital tract TB is almost rare. And coming to the secondary genital tract TB from lungs, almost 50% spread is from lungs and 40% is from lymph nodes. And the spread from kidneys and gastrointestinal tract bones is also seen. And the next is the mode of spread. It can be either the spread can be either the blood, that is hematogenous spread. It can be either lymphatic spread, or it can be direct spread or venereal transmission. Coming to the blood spread, that is hematogenous. If the primary lesion is in the lungs, from a primary pulmonary lesion, it will spread to the genital tract. And if a secondary miliary, that is like gastrointestinal or kidneys or any other vital structures got infected with the TB, the spread to the genital tract through blood is also common. And the next mode of spread is through lymphatic spread. From a primary pulmonary site to intestinal lymph nodes and then to the pelvis, the spread will be there. And directly from the adjacent abdominal organs like gastrointestinal, kidney TB also, it can spread to the genital tract. And next mode of spread is the venereal transmission. Primary genital infection occurs from a male with a urogenital tuberculosis. If a male is having a urogenital tuberculosis, then during the time of sexual contact, the female can have a genital infection, that is either vulval TB, vaginal or cervical lesion. Coming to the pathology, the general distribution of involvement of reproductive organs, that is the most common organs in the genital tract which get infected with the TB is the first primary is the fallopian tube. Almost 90 to 100% we will have it if genital tract has been affected with the TB, then we'll find this tuberculosis in the fallopian tube. And next is the endometrium is the second most common organ to get infected, and next followed by ovaries, cervix, and vulva and vagina. Once this genital tract has been colonized, that is got infected, these viable tubercle bacilli will form a granulomatous lesion, and then these foci will remain silent for many years. And if after the female got her menarche, then this will got reactivation because there will be blood flow to the genital organs, and then this got reactivation and establishment of disease will occur at the time of menarche, and then it will remain dormant. And this tubercle bacilli infect a susceptible host, then it will form an exudate. Initial reaction will be an inflammatory exudate formation, that is with the polymorphonuclear cells, and then these are replaced by mononuclear cells within 48 hours, and then the immunity will develop, as cellular immunity will develop, and this leads to destruction of tubercle bacilli, and then this leads to formation of caseation and necrosis. And after this, there will be reactivation, which leads to formation of classic granulomatous lesion. So this is the main pathology in the formation. Coming to the granuloma, how does it appear means there will be central caseation and necrosis surrounded by giant cells, epithelioid cells, and peripheral distribution of lymphocytes and monocytes and fibroblasts will be there. Why central caseation and necrosis means already the destructed tubercle bacilli, the cellular immunity will be there, so it will cause caseation necrosis, and it will be there in the center. And as the blood supply will be from periphery, the reactivation will be seen. So in the periphery, there will be giant cells, epithelioid cells, and peripheral distribution of lymphocytes, monocytes, and fibroblasts will be there. And next coming to genital tract lesions, that is coming to the individual lesions, fallopian tube, uterus, cervix, vagina, vulva we will discuss. Coming to the fallopian tube, the involvement of both tubes will be around 100%, and this disease is generally bilateral in origin. And mode of spread, most common mode of spread will be hematogenous, that is through blood, then followed by lymphatics, and then the direct spread will be there. And the most common part of the fallopian tube to get infected will be the ampullary part. Generally, fimbrial and interstitial parts will be spared. And the next is the how does the appearance of the fallopian tube will be seen on macroscopic and microscopic appearance. Generally, we'll call it as a tobacco pouch appearance. As we already discussed, the ampullary part is the most commonly infected. It appears dilated with the fimbria and open, and it will be pouting type. And on gross appearance, the tubes will be enlarged and rough grayish tubercles will be seen on the grossly over the fallopian tube. On cut section, we'll see, as we discussed, there will be caseous necrosis in the center and surrounded by all the cells. So this caseous matter will be seen as a yellowish gray in color, and sometimes there may be hematosalpinx, that is collection of the blood or pus in the fallopian tube. So there may be hematosalpinx and pyosalpinx. And as there is an infection, they will form some adhesions, and these adhesions may be seen from the right fallopian tube to the lower border of the liver. So it is nothing but Fitzhugh-Curtis syndrome. And if the infected matter is, if there is any leakage, there will be formation of the abscess and peritonitis and followed by ascites. So these are the images. See, this is the third image. It shows the adhesions between the fallopian tube and the lower border of the liver. And next, the microscopic appearance. There will be Langerhans giant cells, granulomatous tissue, caseation necrosis will be seen, and the tubal mucosa will be totally destroyed or may be seen as a hyperplastic or adenomatous appearance, and sometimes it may be mistaken with the adenocarcinoma. And the other entity is the salpingitis systemica nodosa. This is nothing but the tube will be thickened, nodular thickening of the tube will be seen. This is due to proliferation of the tubal epithelium within the hypertrophied muscular layer, and the nodules are present in the isthmus near the uterine cornea. And this is generally diagnosed through HSG, that is histosalpingography. This is seen as a small diverticulum, and this is not specific to the tubercular infection. This may be even seen in the pelvic endometriosis also. And next, coming to the types of TB salpingitis, that is a fallopian tube TB. It can be either wet type or dry type. Wet will be exudative type, and the dry will be the adhesive type. The wet variety, there will be ascites. That is, as the name suggests, it is a wet, so there will be ascites with straw colored fluid in the peritoneal cavity, and the viscera are covered with small tubercles. And in dry type, there will be dense adhesions with the bowel loops, and this adhesions is due to the fibrosis when wet. After the wet type of TB salpingitis, with the formation of adhesions, this will look like a dry type. And this is all about the TB salpingitis. Now coming to the uterus, tuberculosis of the endometrium, which accounts for 50 to 60%. The tuberculosis involvement of the myometrium is rare. This is generally secondary to the tubal involvement, and corneal ends are the first to be involved. The tubercle, it is situated in the basal layer of the endometrium and come to surface only premenstrually. So all these tubercle bacilli, all these will get lodged in the basal layer, and these come only after to the surface premenstrually. That is after menstruation, as the endometrium will be shedded, and then from the basal layer the tissue will grow, endometrium will grow. Along with this, the tubercle bacilli also come to the surface. After the endometrium is shed at each menstruation, reinfection occurs from the lesion in the basal layer or from the tubes. And initially, there will be caseation and ulceration, and in a severe form, there will be distortion of the entire uterine cavity, and complete obliteration will be seen, like Asherman syndrome, in 2 to 5% of those who got infected. And microscopically, it reveals the characteristic lesion showing central caseation surrounded by epithelioid cells and Langerhans giant cells. And generally, these lesions are focal or generalized type. And these granulomatous lesions are best identified on a day 24 to 26 of the cycle or within first few hours of the onset of the menses, so that we can get a sample, and this sample should be sent in a normal saline, not in a formalin saline, so that we can observe the tubercle bacilli under microscope. And this is all about the endometrium tuberculosis. Then the ovaries. Ovaries will be 20 to 30% will get infected, and the direct extension from the fallopian tube or adjacent peritoneal cavity will be seen. A break in the ovary caused by ovulation may also allow the tubercle bacilli to gain access to the ovarian parenchyma. So after ovulation, there will be some breach in the continuity of the ovary. From there, these tubercle bacilli may enter into ovary, and they may infect the ovary. And next will be the cervix. It accounts for 5 to 15%, and a secondary spread from the infected uterine cavity will be seen. Primary spread, it is generally from the male partner, that is, if the semen of the male sexual partner got infected, then there will be infection to the female also. And the lesions will be either ulcerative or hypertrophic lesions, and this may resemble the cervical malignancy. So before having a diagnosis, we have to rule out the cervical malignancy. Under microscope, the appearance will be the inflammatory atypia with the hypoplastic mucosal changes. And on PAP, we'll see a multinucleated giant cells, histiocytes, and epithelioid giant cells will be seen, which are arranged in the cluster form. And the next is the vulva and vagina, which accounts for 1% of infection. Usually, it is secondary to the extension from endometrium or cervix, and the primary transmission is from an infected partner. As we already discussed, the venereal source of infection from the male partner, it will generally infect vagina, vulva, and the cervix. And so, primary transmission is from an infected partner. Coming to the lesions appearance, these are generally non-healing ulcers and hypertrophic, which resembles a malignancy. It can also cause involvement of the Bartholian glands. Bartholian glands are also will also get infected in these infections. And next, this is all about the pathology of the organs which got infected. Coming to the clinical features, generally the infection is restricted mostly to the reproductive age, and a past history of or family history of pulmonary tuberculosis or any other tuberculosis is very important. And most commonly, this is, as we already discussed, this is secondary. So we have to inquire the patient regarding the past history. And next will be the coming to symptoms and signs. Symptoms, most of the patients will be asymptomatic, and some may present with infertility. Either this can be primary infertility or secondary infertility. And chronic pelvic pain, menstrual irregularities will be seen, and abnormal vaginal discharge. In cases if any pyosalpines or any hematosalpines is there, then we'll get they will present with this. And unusual symptoms will be low grade temperature, weight loss, and fatigue. So coming to the infertility, most of the patients they'll present with infertility. It accounts for 35 to 60% of the complaint. This is the most common presenting symptom, and 10% of infertile women will have a genital tuberculosis. And about 75% present with a primary infertility and 25% present with a secondary infertility. And this infertility, it is mostly attributed to the tubal damage and endometrial adhesions like Asherman syndrome, and at times ovarian damage also may lead to infertility. And next is the menstrual irregularities. These account for 10 to 40%, and irregular menstrual bleeding will be the early presentation. And the most common cause for menstrual irregularity will be due to ovarian involvement or any pelvic congestion or endometrial proliferative lesions will be there. And most of them, they'll have a late manifestation will be the secondary amenorrhea, and this is due to suppression of the ovarian function by tubercular toxin and endometrial destruction and uterine synechia formation, and these patients fail to respond with hormone therapy. And endometrial tuberculosis is a rare cause of puberty, menorrhagia, and postmenopausal bleeding. And the next will be the chronic pelvic pain. Around 20 to 30% of patients will have a chronic pelvic pain. They'll have a dull aching pain, which is aggravated premenstrually, or this can be intermittent in nature, and this is generally associated with the tubo-ovarian mass. And the other symptom will be the vaginal discharge. Cervical or vaginal tuberculosis may be associated with a persistent vaginal discharge. And the other finding will be the abdominal mass. If a unmarried girl with a pelvic inflammatory mass came to you, then it is mostly tubercular origin, and there will be on examination there will be encysted ascites will be seen in intestinal loops with uterine pyometra and adnexal masses. These will look like a lumps, and other symptoms like dyspareunia, vulval lesions, and bathroom gland swelling will also be seen. And next, coming to the signs of tuberculosis, genital TB, there may be constitutional symptoms like low-grade fever, loss of weight. All these will be seen. Apart from this, on per abdominal examination, we'll feel a duffy mass. This may be due to matted intestines, and we can also see tubercular ascites. And on pervaginal examination, if it is a vulvar or vagina TB, there will be ulcers with undermined edges, and on fornical examination, we'll see the thickening of the tubes, and nodules may be felt in the posterior fornix. These are all signs in the pervaginal examination. Before going to the diagnosis of the genital TB, we have to rule out ovarian cyst, broad ligament cyst, and any encysted fluid, PID like pelvic inflammatory disease, ectopic pregnancy, carcinoma cervix, elephantiasis of the vulva, and pregnancy. Those presenting with amenorrhea and abdominal mass, we have to exclude pregnancy. And then puberty, menorrhagia, and postmenopausal bleeding should also be ruled out. And then fungal infection and sarcoidosis should be ruled out. So after ruling all these, we have to go for a diagnosis of tuberculosis. In coming to the investigations, general routine investigations may reveal nothing significant, so specific investigations has to be done. These among this CBP, in CBP we'll see a differential WBC count, and we'll have a lymphocytosis, and ESR may be raised, but it is a non-specific indicator. And coming to the Monto test, positive report will be seen those who are exposed to tubercle bacilli in the past, and almost 90% of cases are positive with this Mantos test. And though it is a negative, it goes against to the tuberculosis. And coming to the specific investigations of genital tuberculosis diagnosis, we'll go with hysterosalpingography. But those we are suspecting active lesions, this HSG is contraindicated, and this should be performed, can be performed in asymptomatic women. Those who are having a lead pipe appearance, that is rigid non-peristaltic pipe-like tube, and who are having a bleeding and variation of filling defects, and calcification of the tube and corneal block will be seen. And tobacco pouch appearance of the hydrosalpins and hydrosalpins and pyrosalpins can also be seen. So these are the images. Okay. The next will be the ELISA test, that is IgG and IgM test can be done. These are mycobacterial purified protein antigens. And next is the ultrasound examination. On ultrasound examination, we can see abdominal mass, and if adnexal mass is there, then FNAC can be done, that is through ultrasound guided, and Bruchard biopsy can also be done. And the appearance of the fallopian tube, it will be dilated and thickened. Either hydrosalpins or pyosalpins can be seen in the ultrasound. And next is the endometrial cavity. The appearance will be like this. There will be heterogeneous or with hyperechoic areas, that is foci of calcification or fibrosis can be seen. And in intrauterine cavity, there will be adhesions, that is like Sherman syndrome, and the cavity will be distorted with myometric cyst will be seen, oligamic myometrial cyst will be seen, and follicles with echogenic rims in presence of endometrial fluid along with the hydrosalpins. These are all findings in the endometrial cavity, those got infected with the TB. And next will be the histological examination, PCR testing. The tissue, the endometrial tissue, which we have got from the either dilatation and curettage or hysterosalpingography or histoscopy, we'll send it for a histological examination, PCR testing. This is generally done, as we discussed, at around 24 to 26th day of our cycle, and this is sent in 3 portions. One is for histopathology, the other will be for PCR testing, which is a rapid, sensitive, and specific testing. And this report will be available in 24 hours. And the third will be the guinea pig inoculation and tissue culture will be done. So this is the three proportions which will be sent for investigation. And the other will be the acid-fast staining of the endometrial tissue to detect the Mycobacterium tuberculosis, but this is not so accurate. And coming to the hysteroscopic findings, in the uterus, the endometrial cavity, there will be synecdoche, that is adhesions may be seen, and obliteration of the cavity will be seen, and rarely presence of ulcers will also be seen. And coming to the laparoscopy, there will be thickened rigid tubes, hydrosalpinx, pyosalpinx, and tubo-ovarian headache cell masses. Tissue biopsies can also be taken from under laparoscopy. The laparoscopic images. See, there are the caseous nodules in the utrovesical pouch and on the anterior abdominal wall. And on chest X-ray, this is generally for the primary lesions, and radiography of the bones can be taken. And the other test will be the NAT, that is nucleic acid amplification technique, and BACTEC, which is a rapid culture method, can also be done. And if a male partner, we are suspecting a male partner with a TB, then we have to do a semen culture. And other biochemical markers will be adenosine and deaminase activity. This is tested in the aesthetic fluid. And next, coming to the treatment, this is the treatment. Those who are having female genital tract TB, and if it is a new confirmed case or clinically diagnosed case or previously treated, which who are having a drug sensitive, then we'll go with the depending upon the weight, we'll divide the treatment under two regimens, that is intensive phase and the continuation phase. This is given daily for 2 months. The intensive phase is given daily for 2 months, and the continuation phase is given daily for 4 months. This is depending upon the weight of the female. If she's under 45 kgs, then we'll go with the 2 HRZD, and if is and the dosage will be rifampicin, isoniazid, pyrazinamide, ethambutol. The dosage will vary according to the weight of the female. And in continuation phase, we'll go with the 4 months of HRE only. Will not go with the pyrazinamide. And if she's a multi-drug resistant or probable multi-drug resistant female genital tract TB case, then depending upon the weight, and we'll divide it into intensive phase and continuation phase. The intensive phase will be given daily for 6 to 9 months, and continuation phase will be given for 18 months duration. And the drugs will be in intensive phase: kanamycin, levofloxacin, ethanamide, cycloserine, pyrazinamide, and ethambutol. And in continuation phase, we'll give a levofloxacin, ethanamide, and cycloserine and ethambutol. So these are the first line drugs. Coming to the dosage, like depending upon the kg body weight, isoniazid will be 5 mg, and rifampicin will be 10 mg, pyrazinamide will be 20 mg, ethambutol will be 15 mg. Among these, the ethambutol, it is a bacteriostatic. The remaining 3 will be the bactericidal. And next, the second line drugs, like we discussed, streptomycin, capreomycin, ethanamide, p-aminosalicylate acid, and fluoroquinolones, kanamycin, amikacin. These are all the second line of drugs. These most commonly, these will inhibit either protein synthesis or folic acid synthesis, or it will generally affect the DNA or RNA strands. And coming to the side effects of these drugs, in isoniazid treatment, we'll have a peripheral neuropathy, seizures can be seen, and hepatitis and lethargy will be seen. Rifampicin, mostly it will affect the gastrointestinal system, and hepatitis will be seen. Pyrazinamide, it will also infect the side effects will be hepatitis and gastrointestinal irritation, and hyperuricemia will be seen. And ethambutol, the side effect is optic neuritis. And those patients who are having HIV infection along with the tuberculosis, then we have to treat both HIV and TB. AGT should be started to all patients with drug sensitive or drug resistant TB and HIV, irrespective of CD4 count. And as early as possible, usually by 2 weeks of initiation of AGT, we have to start DOTS also. In a drug sensitive TB, on second line ART, rifampicin is replaced by rifabutin. And this female genital tract TB is treated with reserve drugs for 18 to 24 months, like for pulmonary multi-drug resistant TB. And coming to the surgical management of genital tract TB, coming to the indications, if there is an active persistent lesion, or if there is a progression of lesion from salpingitis to uterus or cervix, anything, or if any persistent of large inflammatory mass and persistence of fistula, and any symptom persistence, in all such conditions, we'll go for a surgical management. So what are all the types of surgeries? we can go for a total hysterectomy with bilateral salping oophorectomy, or if it is a hypertrophied vulva, that is vulval TB, then we'll go with a vulvectomy. And uh, if she's having any adnexial mass, tuber-ovarian mass, we'll remove the adnexial mass. And if she's having any pyometra, then we'll drain the pyometra. If there is a fistula formation, then we'll repair the fistula. And coming to the follow-up, post-operative chemotherapy for 6 to 12 months should be given, and follow-up after 5 years should be done. And after curettage is done to check any reactivation is there, and HSG should not be done. Recently, we have developed two free regimens, that is injection-free regimens, that is bedaquiline and delaminid. This has been recommended by WHO, and this has been updated in the 2018. So this is all about female genital tract TB. If you are having any doubts, you can ask me. Okay, if you are not having any doubts, we'll close the class.